Hi, my name is Erin from Educated Nurse and welcome back to our EKG series. I'm doing another educational quick video. Today we're going to hit on atrial dysrhythmias. We're going to look at atrial fibrillation, atrial flutter, premature atrial contractions, and SVT, which is supraventricular tachycardia. If you're looking for other dysrhythmias, you can look in our whole EKG series on YouTube. If you're new to us, you can follow us on Facebook and Instagram, and then we also have a store on Etsy and Shopify where we sell nursing study guides, templates, and merch. So check us out. All right, in our first video in the series, we talked about normal sinus rhythm and what makes normal sinus rhythm. So just as a review, for normal sinus rhythm, you have to hit these 10 points. The heart rate should be between 60 and 100. If it's low or high, it's not normal, okay? Then you're looking at a bradycardia or a tachycardia of some sort. And that is the atrial rate and the ventricular rate. The rate, rhythm, and regularity should be regular. So when you march out your P waves, P to P, and the QRS to QRS, it should march out in an even and regular fashion. There should be a P wave. There should be a P wave before every QRS. And the measurements on the P wave, the PR interval, and the QRS should all be within normal limits. Check out the normal sinus rhythm video if you need more information on measurements. Also, the ST segment should be at baseline, so when that QRS complex comes back up, the ST segment is flat. It should not be elevated or depressed, which could be a sign of ischemia or a heart attack. There should not be a U wave. And lastly, there should be no early beats or late beats. And those are your 10 points to normal sinus rhythm. You need all of those things in order to meet criteria to be normal sinus rhythm. Any deviation from that is an arrhythmia. So let's look at some atrial arrhythmias. All right, let's dive into PACs or premature atrial contractions. So we just talked about what makes normal sinus rhythm. Let's look at why a PAC is considered an arrhythmia or a dysrhythmia, okay? So when you look at your 10 points to normal sinus rhythm, when you have a PAC, the rate should be normal. However, there are some instances where the rate might be abnormal, and that's going to depend on what the underlying heart rhythm is. If you have a patient who is in normal sinus rhythm and they're having an occasional PAC, their rate is probably okay. But you can have PACs with other dysrhythmias, which could cause the underlying rate to be elevated or low, depending on what that is. In this particular EKG, we can see that the rate here is 60. So that's okay because we know that the heart rate should be between 60 and 100. Now, the rhythm and regularity on a PAC is going to be irregularly irregular. Anything that deviates from normal sinus rhythm is irregular. And with a PAC, there's no rhyme or reason to when the PACs come. It's not like they come every other or every third or whatever. They could, but in this instance, it doesn't. So because it's just, there's no rhyme or reason to it, we call it irregularly irregular. Now the P waves, there are P waves, and in some cases with PACs, they can be premature or hidden. And I'm going to talk to you about PACs and how you know the difference between a PAC and a PVC in just a minute. The PR interval should be normal. The QRS should be normal. The ST segment should be at baseline. It should not be elevated, should not be depressed. There is a T wave. There should not be a U wave. There are early beats, but there are no late beats. So let's talk a little bit about why this happens. So a PAC, or premature atrial contraction, normally the thing that stimulates the atria to contract is the SA node, which is high up in the right atria. The SA node fires and sends an impulse across the atria to the AV node, and that stimulates the atria to contract. Now, every cell in your heart has the ability to be its own pacemaker. So when you have a premature atrial contraction, you're going to have an entire beat. And when I say an entire beat, I mean the P wave, the QRS, and the T. They're all going to come early. So the whole complex, the P wave, the QRS, and the T wave are all going to come early. And it's coming early because there's some other irritable site somewhere up in the atria that's saying, I want to fire, I want to fire. And some cardiac cell goes rogue and it just fires on its own. It's not coming from the SA node, okay? So the entire beat, the P wave, the QRS, and the T wave are early. And we'd be able to tell that it's early if we marched out the P's, right? If we drew our box and we marched out how far apart those P waves are, you would notice in the middle that those two P waves are closer together than the other ones. In this EKG, the SA node eventually will kick in and start beating again, and you know that because it's regular and you notice those P waves again. In the one that's circled on the screen, there is a little blip of a P wave, but sometimes the P wave gets hidden and you can't really see it. That's why it says the PR interval is questionable, okay? But typically a PAC versus a PVC, you're going to have a big, wide, ugly, bizarre complex, just a QRS complex, versus the PAC is an entire complex, P wave, QRS, T wave, and the whole thing beats early, okay? So let's look at what causes this, how we diagnose it, and what we do about it in the next slide. All right, what causes PACs? There's a variety of reasons that cause PACs. They can occur in healthy adults for no reason, okay? A lot of times we see them in patients that are under a lot of stress. They consume a lot of caffeine or stimulants, electrolyte imbalances, alcohol use, tobacco. If they're super tired, I know I've had PACs and PVCs when I haven't had a really good night's sleep. So that can certainly happen. Electrolyte imbalances, hyperthyroidism, COPD, and heart disease. Patients might be asymptomatic. They might not even know that they're having them. You might just hook them up to an EKG if they come to see you, and you might catch them randomly. Some patients say like, oh, I feel like my heart's skipping a beat, or there's a pause here and there. Otherwise, like I said, most of them are asymptomatic. How do we treat it? You might not need to do anything. Most patients, especially if they're asymptomatic and they have adequate perfusion, you don't need to treat them. If they are symptomatic and they're not feeling well, they might have some, chest pain or shortness of breath, or they might feel their heart skipping a beat, or they might get dizzy and lightheaded. Some might even pass out if they have enough of them. So you'd want to support their ABCs, have them remove the stimulants and stress and all the bad things in their life that could be potentially causing this. Even chocolate can cause this, unfortunately. So just removing some of those stimulants, making sure that they're not getting stressed out, making sure that they're exercising, getting a good night's sleep. Just try some non-invasive things first. And if that doesn't work, beta blockers can be an option to help with rate control. There's a thought that if you slow down the rate, you'll slow down the frequency or stop the PACs, because the SA node will be the one that's constantly firing. So those are just some causes, symptoms, and treatments for PACs. Atrial fibrillation. You can just tell by looking at this EKG that something is abnormal, right? There's way too many P waves. It's irregular. It looks bizarre. We know it's a dysrhythmia, right? What is atrial fibrillation? Well, in a normal heartbeat, right, the atria will contract and then the ventricles will contract, like atria, ventricles, atria, ventricles. In atrial fibrillation, there's total disorganization of the atria itself. So the atria are going to quiver, and every now and again, the ventricle is going to squeeze, right? All the while, the ventricle is sitting there with blood pooling in the bottom. So the atria are squeezing at a totally disorganized fashion, and there's blood pooling in the bottom of the ventricles, and eventually it squeezes. In a patient who's at risk for clots, that's a problem because this blood is just sitting here, and then when the QRS or the ventricle does squeeze, it could send clots someplace. That's bad, right? So atrial fibrillation is total disorganization of the atrial electrical activity. There's no discernible P waves, although you can kind of see in this EKG the fibrillatory waves. They're not considered P waves, they're considered fibrillatory waves, okay? And there's so many of them, it's kind of hard to count. I'm sure you could just be like, well, Erin, I can go count them. You probably can, but the atria rate is going to be anywhere from 350 to 600 beats a minute. So every time the ventricle squeezes once, the atria is going to be squeezing 6 times and then a ventricle squeeze. All right, so something like that. That's bad, right? And what causes atrial fibrillation in these multiple fibrillatory waves? Just like we talked about with PACs, there's multiple cardiac little cells in the atria that are saying, I want to beat, I want to beat, I want to beat, I want to beat. And they all just do their own thing. And the SA node is not the one that's firing. It's all these ectopic spots in the atria that are firing, 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 and you're getting all these little fibrillatory waves, okay? Again, the problem with this is while the atria are spazzing out up here, the ventricle's just sitting and the blood is pooling and the blood is clotting. Definitely a risk for thrombi or clots, okay? So let's look at our 10 points to normal sinus rhythm. When we look at this particular EKG, I tried to count them, but obviously I couldn't count every little blip, but the atrial rate is greater than 200. It's probably closer to 300, but you really can't tell with all the fibrillatory waves. The ventricles, you can count them, there's 9, so your ventricle rate is 90. Obviously, your rhythm and regularity here is irregularly irregular. There's no rhyme or rhythm to this. You can see that you can't even count the P waves, but you can see that the QRSs are not marching out in an equal manner. Okay, the P wave, we don't know because it's a bunch of fibrillatory waves. Can't measure the PR interval. The QRS should not be affected. Okay, so the QRS should be normal. So instead of the SA node firing, sending an impulse across the atria to the AV node, all these multiple sites in the atria are firing. And eventually electricity does get down to the ventricle, so it does squeeze, but there's no rhyme or reason to it. The T wave should be normal. It should be at baseline. Early beats, we don't know, right? Because there's all these fibrillatory waves, and then the QRS goes whenever it wants. So we say that it could be early, could be late. We just don't know. Just looking at this though, you can tell that it's atrial fibrillation. It's irregularly irregular, and you're going to see those little tiny fibrillatory waves. Pretty indicative. You can tell this apart from Aflutter because Aflutter has a very distinct pattern, and we're going to look at that next. First, let's figure out what causes atrial fib, some diagnostics, and some treatments. All right, what causes AFib? What are some symptoms and what are some treatments? The main causes of atrial fibrillation are heart disease, coronary artery disease, valvular disease, hypertension, heart failure, pericarditis, so infections around the heart, caffeine use, electrolyte problems, stress, lack of sleep, that kind of thing. Some patients will go into atrial fibrillation and convert on their own, and they probably won't have any symptoms. Some people live in atrial fibrillation and it doesn't really bother them. Other patients, again, if you think about it, the atria are freaking out, doing their thing, and then the ventricle squeezes every now and again. During that time, while the atria are freaking out and the blood is just sitting here pooling in the ventricle, there's no cardiac output, right? So blood isn't getting to where it needs to go out to the rest of the body. So patients are lightheaded and dizzy. They'll have chest pain, shortness of breath. They might feel palpitations or weak or have a syncopal episode. Okay. How do we treat atrial fibrillation? Support the ABCs. If they're short of breath, they're hypoxic, put on some oxygen, start a line, give them some fluids perhaps, check their electrolytes, replace those if they need to be fixed. One of the main goals with atrial fibrillation is that we get their rate under control. Most of the time, we're going to do cardizem or diltiazem, digoxin, but usually cardizem is the go-to. Amiodarone can be used for rate control, but it's not as commonly used as like a cardizem, diltiazem. Adenosine is also another option. However, adenosine, if you give that, and we're going to talk about this a little bit more in the SVT portion, but adenosine you have to be really careful of. The patient needs to have only been in atrial fibrillation for a little time, or they need to be pretty anticoagulated, because with any medication like adenosine, or if you're going to do cardioversion, where you actually shock the patient in hopes that their heart stops and restarts in a normal rhythm, you have to be worried about sending clots. off to places. So you have to be really careful with that. Most of the time, we're going to try cardism or diltiazem. Cardioversion can be a possibility, and that's where we are going to provide a low dose shock. It's not as high of a shock as like a defibrillation. And we'll talk about it again with SVT in a little bit. It's an option, but again, use cautiously if the patient's not anticoagulated, because you can send clots. The goal of anyone who's in atrial fib or atrial flutter is that they get on an anticoagulant. Because they're high risk for clots, they need to go home on like Coumadin, heparin, Lovenox, something like that, so they make sure that their blood stays really thin so they don't have clots. All right, atrial flutter's up next. All right, up next is atrial flutter. Take a look at this EKG and remember back to the atrial fibrillation EKG. There's something that's a little bit different about this one, right? There's some regularity to it, and it's the sawtooth or shark tooth appearance of those P waves that makes Aflutter stand out from Afib. But let's dive into this a little bit more, okay? So in atrial flutter, when we look at those 10 points to normal sinus rhythm, again, the rate's going to be high. The atrial rate's going to be greater than 300. In this particular situation, their ventricular rate is 120. So they are a little bit tachycardic with this. It is, when you look at the rhythm and the regularity, atrial flutter is regularly irregular, meaning it is an irregular rhythm because it does not meet the 10 points to normal sinus rhythm, but there's regularity to that irregularity. And you can kind of see here that there's multiple P waves for every QRS, but if you were to march out those QRS complexes, they'd be consistent and spread apart consistently. So we call it regularly irregular. There is regularity to the irregularity, okay? Are there P waves? Yes, there's actually multiple, and there is one before every QRS. So sometimes you'll see like a 3-to-1 flutter, meaning there's 3 P waves to every 1 QRS. A 2-to-1, a 4-to-1, okay? So there is regularity to the irregularity. Your PR interval should be normal. Your QRS complex should be normal. The ST segment will be at baseline. There will be a T wave. There shouldn't be a U wave. There are early beats, but there should not any late beats. And again, the atrial flutter is happening because the SA node is not firing. There is one focus. So in atrial fibrillation, we talked about there's many cells in the atria that are firing, which is why we're getting all those fibrillatory waves, and it's irregular. In atrial flutter, there's one cardiac cell in the atrium, not the SA node, one cardiac cell in the atrium that's firing and doing its own thing, sending out its own beat, and that's why it's regular. Okay, that's one of the reasons why it's regular and why the P waves have that uniform shark tooth or sawtooth appearance. Okay. All right, let's look at some causes, symptoms, and treatment for atrial flutter. Very similar to atrial fibrillation, to be quite honest. It's kind of rare to have in a healthy heart, but it can be from coronary artery disease, heart failure, hypertension, valve disorders. You can see this happen in patients who have lung disease or PE, cardiomyopathy, hyperthyroidism, and medications such as digoxin or epinephrine. I've actually seen a patient, a young, healthy patient, who got stung by a bee, and we had to give them epinephrine because they went into anaphylaxis, and then they went into atrial flutter after that. We watched them for a few hours, and once the epi kind of wore off, they converted on their own, but that was like the first time I had seen that with epi, so that was kind of interesting. Symptoms, they can be asymptomatic again. If they do have symptoms, most of them are going to have chest pain, shortness of breath, dizziness, lightheaded, palpitations, weakness, some anxiety, and that's just because they're not getting oxygen up to their brain. But most of the time, they might be asymptomatic, or I said, chest pain, shortness of breath are the most common, I would say, and just generalized feeling not well. Treatment for this, again, support the ABCs. We can consider adenosine, maybe. Depends on how long they've been in it and if they're stable or unstable. Diltiazem is our go-to, again, for rate control. Amiodarone, maybe, and digoxin. Again, we can consider cardioversion, but it really depends on how long they've been in it and if they're anticoagulated. And then again, if the patient's going to stay in Aflutter, or we can't get them out of Aflutter, or we can't cardiovert them because they're not anticoagulated, they need to be on anticoagulation for risk of clots. All right, the last atrial dysrhythmia we're going to talk about is SVT, or supraventricular tachycardia. Some people might not categorize this as an atrial dysrhythmia. I have always thought of it as an atrial dysrhythmia because it occurs above the ventricle. Supra, so going back to your medical terminology class, supra is above. So it's above the ventricle. And then tachycardia, we know what that means, right? It's fast heart rate. So above the ventricle tachycardia, that's why I consider it an atrial dysrhythmia, okay? And actually, it's considered an atrial reentry. So there's a problem with the electricity or the reentry, which causes that tachycardia. So you'll probably see some people consider it ventricular. I have never done that. I just consider it an atrial dysrhythmia. Anyways, SVT. So when you look at the 10 points to normal sinus rhythm in SVT, the rate's going to be fast, right? In this particular EKG, if you count it all out, the rate is 190. So pretty fast, right? And it needs to be over at least 150, 160 to be considered SVT. Now there is regularity to the irregular. It's irregular because it does not meet all the 10 points for normal sinus rhythm. Okay, so, but there is some regularity to how those SVT or the QRSs march out. All right, P wave, there's no P wave here, which is very indicative of SVT. This is the different, or one of the differences between sinus tachycardia and SVT. Sinus tachycardia, the whole complex is going to be fast. So the P wave, the QRS, and the T, there's going to be a lot of them because the rate's going to be fast. You know it's SVT because there are no P waves. So when you look at this really fast tachycardia, and they're going to be clipping along, their heart rate is going to be like beep, 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 beep on the thing, on the EKG monitor, it's going to be fast. But you're going to look up and you're going to be like, oh, yep, there's no P waves. It's SVT. All right. You can't really see them. Sometimes they're not there at all because there's another site that's firing above the ventricle that's causing this electrical impulse. Other times we say that they're buried in the QRS. So either way, you won't see a P wave. The PR interval, you can't even measure it. It's going to be so short. If you do eventually have a little P wave here and there, it's going to be pretty short because it's going to be so fast. The QRS should be normal. The ST segment should be at baseline, or at least, somewhat close to baseline. There should be no U waves and no early beats and no late beats. All right, what causes SVT? Well, in a normal healthy person, it could be stress related. It could be lack of sleep, stimulants, caffeine, recreational drugs, cocaine, meth. Deep inspiration can sometimes put you into SVT, but then most people just convert on their own in a few seconds. Overexertion, and again, lack of sleep kind of goes with overexertion. Rheumatic heart disease, patients that take digoxin, coronary artery disease, lung disease, especially cor pulmonale. You can see SVT in asthmatics too sometimes, but your primarily ones are going to be like your stimulants and then your heart disease and your lung disease. Symptoms for SVT, heart rate's going to be 150 to 220. Okay, no discernible P waves on that EKG. They're going to be short of breath because their heart rate is going to be chucking along super fast. Palpitations, they might be dizzy, they might have chest pain, and they're probably going to have low blood pressure because the heart rate and the blood pressure are going to try and compensate for each other. How do we treat SVT? The easiest method is to do vagal stimulation. Okay, vagal stimulation is just have them take a deep breath and bear down like they're going to poop. So, like that. If that doesn't work, you can try carotid massage, right? But only do one set at a time. You don't want to carotid massage both sides and cut off blood flow to the brain. Your patient's going to pass out. There are some other methods that you can do with vagal stimulation. You can look them up on YouTube. I've seen some success where the patient is sitting up in the bed and you have them blow into like a 10 cc syringe as hard as they can. to try and push the end of the stopper off the syringe. And you want to have them like take a deep breath in, blow it out, hold it, hold it, hold it, hold it, hold it, hold it. As soon as they're done, you flip them up so their feet are above their head and their head is back in the bed. I've seen that work a couple of times. One of our ER docs loves to do that. If none of these things work, especially if the patient is symptomatic, you can try adenosine. So adenosine, your very first dose is going to be 6 milligrams. You can repeat it, or you can just go right to 12 milligrams. Then you probably shouldn't do any more after that. With adenosine, it's got a 6-second half-life. So when you get this and you're going to give it, you got to do a couple of things. It's recommended that you put it in an IV, a large bore IV, so like a 18 or a 20. And you put it in the right AC. You can go left AC, but right is actually closer to the heart. So it's recommended that you do right AC, and that you hold the patient's arm up so it gets ready to go right into central circulation. As soon as you push the adenosine, and you're going to push it really fast, you slam in normal saline behind it. So what we have at work is this thing called a stopcock. It's like a 3-way stopcock. You put one end on the end of the IV tubing. You've got another end that goes off to the medication, and then another end that goes to like a saline flush. And it's got a little valve on the top, and you just turn it to the medication. You turn it open, you slam the medication, and then you slam the saline behind it. Again, it's got a 6-second half-life, so you got to get that in. I've also seen it given where they flush right away, and then they just, put the IV fluids on a pressure bag and squeeze it in really fast. Just remember it has a 6-second half-life, so you got to get it in and rapid saline flush afterwards to get it into central circulation. One thing you should tell your patient, though, is that they're going to feel kind of an impending sense of doom. They're going to feel their heart stop, which is really scary because they're awake, okay? Tell them that that's going to happen, but you need to be prepared that it does not happen. So you need to have your airway supplies. You need to have oxygen. You need to have stuff to intubate. You need to have stuff to shock the heart or at least start CPR in the event it doesn't restart. Adenosine will interrupt the electrical impulses. The heart will stop, and then the goal is that the SA node starts firing and kicks in and restarts and gets the heart going on its own natural rhythm again. But you need to be prepared that it does not work. Okay, so have all your ABC stuff ready to go. So that's adenosine. And again, 6 milligrams, then you can do another 6, or you could just go right to 12. It depends. It's physician dependent. If you don't do adenosine, you can do cardioversion. Cardioversion is similar to defibrillation. However, it's a much smaller dose. You're looking at about 50 to 100 joules with cardioversion. And when you set up your monitor, you have to set it to sync, not defibrillate. It has to be on sync. It's synchronized cardioversion. And when it syncs, it's looking for the top of the QRS, so it knows exactly when to shock the patient, so it can hopefully again restart. If you have time, if the patient is somewhat stable-ish, it's really nice to give them a little sedation before you do this. Otherwise, if it's emergent, you might not be able to sedate your patient. When you put the pads on, they go one on the front, one on the back, and some will do upper right, lower left, kind of like defib pads. Our docs like to sandwich the heart, one on the front, one on the back of the chest. They're going to get a shock, and they're going to be awake, and most patients say, God, I feel like I just got hit by a semi, or I feel like I got kicked in the chest by a horse, okay? They feel that, and sometimes the skin will burn, the hair will burn, so try and sedate them if you can, or at least give them some medication like Versed or fentanyl or something, morphine, just to, make it a little easier on them. But if they're unstable, you just got to do it, right? And just like with adenosine, just prepare that the heart might not start up again on its own. So have all your airway, oxygen, breathing, and circulatory support stuff ready to go in case it doesn't. All right, so that's SVT. All right, thanks for watching our quick video here on atrial dysrhythmias, PVCs, Afib, Aflutter, and SVT. Catch our other videos in the EKG series. We've got ventricular dysrhythmias, normal sinus rhythm, blocks, NSTEMI versus STEMI, and a lot more. If you're struggling with EKGs or you want to learn a little bit more, I have a whole EKG study guide with over 50 pages on how to interpret EKGs and NCLEX style practice questions, along with templates and some nursing merch in our store on Etsy and Shopify, so check us out. Otherwise, just follow and subscribe to our YouTube channel. There's going to be tons of videos in the next few weeks going over multiple systems, and follow us on Facebook and Instagram. Reach out anytime if you have questions. Thanks for watching the quick video. Catch you next time. Bye-bye.